Good morning, everybody, and welcome to the 2024 Virtual Health Summit hosted by Family Voices of California. My name is Nick Lutton, and I'm the Program Manager for Family Voices of California, and I'm going to be your guide and your MC through this incredible journey of knowledge and empowerment that we set to embark upon together today. So we're gathered here, even though miles apart, united by a powerful common purpose: to enhance the lives of children and youth with special healthcare needs. Over the next 2 days, we'll navigate through a wealth of insights, experiences, and expertise, all focusing on sharing our knowledge and improving access for our children. As we open the summit, I'm reminded of the strength that lies in our collective voice, a voice that carries the stories, the challenges, and aspirations for families across California. It is that voice that will echo throughout our sessions, stirring action and igniting change. Our agenda is packed with enriching discussions, starting with a deep dive into California Children's Services and culminating tomorrow with a comprehensive overview of enhanced care management. And let's not forget the impactful breakout sessions designed to address the specific needs and concerns within our community. Today, we'll be introducing our keynote speaker, Senator Anthony Portantino, as well as presenting to you all of the recorded keynotes from Assemblymember Jim Patterson and Assemblymember Steve Bennett, all champions of the realm of children and youth with special healthcare needs. As a father of 2 children with intellectual disabilities, I'm very proud that we have legislators on to be able to empower our health summit. We owe a tremendous thanks to our sponsors for their unwavering support, without which this summit would not be possible. And their commitment fuels the progress and amplifies the impact of our work. So now it's my great honor to introduce a leader who embodies the dedication that we all share. Wendy Nykirk-Rhodes. Wendy is the Executive Director of Support for Families for Children with Disabilities in San Francisco and has been a relentless champion for the empowerment and betterment of children's lives. So please join me in welcoming Wendy to the virtual stage, ready to share her valuable insights and set the tone for our summit. Everyone, Wendy Rhodes.
Thank you so much, Nick. I am delighted to be here. Good morning, everyone. Thank you so much for joining us today. As Nick mentioned, I'm Wendy Nykirk-Rhodes. I'm the Executive Director of Support for Families of Children with Disabilities. We serve families in San Francisco and also have the immense honor of being the fiscal sponsor for Family Voices of California. I am filled with so much pride and excitement today as we open this 2024 Family Voices of California Virtual Health Summit. This 2-day summit brings together families of children and youth with disabilities and complex medical needs, along with agencies and providers from all across the state, for a groundbreaking event that showcases our commitment to enhancing the well-being and development of children and youth with special healthcare needs in California. Every year, Family Voices of California orchestrates this pivotal health summit to unite families, youth, providers, policymakers, advocates, state agencies, insurers, and other vital stakeholders. Our goal is to confront and conquer the health challenges that face one of California's most vulnerable populations, children and youth with special healthcare needs. Today's gathering is so much more than a conference. It brings all of us together to foster progress, inspire hope, imagine possibilities, and launch groundbreaking collaborations. Support for Families' mission is to educate and empower families so they have the resources and support to access whatever services their child needs, and to nurture a community where each family's unique journey is supported and every child has the opportunity to thrive. The unity and strength of our mission resonates through our partnership with our Executive Council member agencies for Family Voices of California. So today, I want to extend my heartfelt thanks to the Eastern Los Angeles Family Resource Center, the Family Resource Centers Network of California, and the Alpha Resource Center. Your unwavering commitment amplifies our collective efforts, and solidifies the foundation of our achievements. I also want to take a moment to thank Nick. Nick Lutton's the Family Engagement Manager for Family Voices of California. And I want to say thank you for his unwavering work planning this conference, and to our consultant, Holly Wong, for her wonderful support in making today possible. All of our work and this summit are made possible by the generosity of our sponsors. Thank you so much to CalOptima Health, the Lucille Packard Foundation for Children's Health, California Children's Hospital Association, the Lucille Packard Children's Hospital, Tri-Counties Regional Center, the Children's Specialty Care Coalition, the Pediatric Day Healthcare Coalition, and Disability Rights California. Your contributions are critical to our success and are vital to advance healthcare for our children. This summit is a powerful testament to what we can achieve when we unite, bringing together our knowledge, compassion, and dedication. Let's continue to build on this foundation to center the needs of families and children with complex medical needs and ensure a brighter, healthier future for every child and family in California. It is my distinct honor today to introduce Senator Anthony Portantino. Senator Portantino represents California's 25th State Senate District, which is an area full of notable landmarks and institutions. He is fervently committed to children and youth with special healthcare needs and healthcare requirements. His work includes the landmark Senate Bill 805, which broadens autism treatment coverage under insurance and offers diverse care options for children with autism. This legislation highlights his understanding that early intervention and personalized care are crucial for successful treatment outcomes. Senator Portantino has also championed the educational needs of children with unique challenges through Senate Bill 1016, enhancing special education services for students with fetal alcohol spectrum disorder. His dedication ensures these students receive the recognition and resources necessary for educational success. In understanding the intersection of healthcare and education, Senator Portantino has been instrumental in the passage of Senate Bills 14 and 224, emphasizing the importance of mental health education in schools. These initiatives equip schools with the tools to destigmatize mental health care and to create supportive environments for all students, especially those with behavioral health needs. Apart from his legislative achievements, Senator Portantino's career spans film and television production, civic engagement, and public service, including a term as mayor of La Cañada Flint Ridge. His diverse experience greatly enriches his advocacy for children and youth with special healthcare needs. Senator, thank you so much for joining us today.
And I wanted to go ahead and jump in and say thank you to Wendy for that unbelievable presentation and opening, especially introducing Senator Portantino. Senator Portantino is rushing to his computer right now because he had a press conference and was nice enough to go ahead and be part of this. So we're just waiting on him, which should only be a couple of moments, which isn't an issue. Wendy and myself have been a part of multiple health summits. And I guess one of the things, Wendy, that I would love to ask you is from the parent's perspective, as I know you're a parent, as well as I am, from previous health summits, what do you think is the takeaways from the summit when it comes to families as well as professionals? What do you believe from your organization and just statewide that people get out of coming to the summit as well as engaging within the speakers and the breakout sessions?
Sure. I think as a parent, it is always incredible to connect with other parents. Almost everything that I have learned about services for my child, I've learned from another parent because they've navigated those services. They have figured out how to cut through bureaucratic systems and tape that we're all stuck in to get what their child needs. And so connecting with other families has been transformative for me. But it's also amazing to see providers, stakeholders, medical professionals, policymakers, funders and philanthropic leaders and agencies and healthcare centers from across the state. It reminds me that they're interested in creating an environment where my child can have what he needs, and that they are constantly working on their end to innovate and to improve these systems, which at their heart all want the best for our children, but getting there can be really complicated sometimes. So whether you're a parent navigating those systems from the front end, or you are a provider or an agency working in those systems on the back end, or a policymaker or an executive trying to move the needle and create more paths for access, it's incredible at these health summits to see everyone coming together with their different perspectives, trying to make California a place where children and youth with complex medical needs can truly receive the support that they need and deserve. And so that none of us feel alone in that work. What has it been like for you?
You know, as a father, it's really interesting for me, on the opposite end where we put all this together, as you all would imagine, being here, is that we have, it's very difficult to get these large systems of care and subject matter experts in one room together, right? And one of the things that I learned from the pandemic is that through this Zoom platform or through the online platform, we were able to do that. I like the opportunity to be able to jump from room to room and to be able to pick specifically what it is that helps me and my family. Because some of the topics are not, they're not conducive with my family. My children, you know, have intellectual disabilities and are regional center clients. And so there are different aspects of it that really help me in my advocacy journey as well as my child. And I think while these experts and these parents explain their stories, we get a nuanced view of the way in which people can move forward with very complex systems of care. And for me, it's been something that I know is not only extremely important, but it's an event that I have always attended even before I worked with Family Voices of California. And I've always found it to be so interesting because it really is one of the places where it's a one-stop shop for extremely in-depth conversation about very complex systems. So if that's what you're here for today, which I hope you all are, this is exactly what it is that we hope to not only present to all of you, but to be able to receive some feedback. And again, a lot of these topics relate directly to you and your children. And so we really hope that you enjoy not only the breakout sessions, but the plenaries. And I see that Senator Portantino has just joined us straight from his press conference. And Wendy did a fantastic introduction to Senator Portantino. And we both would like to welcome you, Senator. Thank you so much for joining the Family Voices of California's 2024 Virtual Health Summit. And with that, because I know we're running behind time, I'm going to just go ahead and leave it to the Senator.
Well, thank you. Sorry, I was a couple minutes late and really appreciate the opportunity to be here. My pin is upside down. Let's make sure. Oh, I've made it worse. Make sure the bear's right side up. So it's great to be here, and you know, obviously, impact on families' healthcare. You know, I'm a dad myself. I've got two great daughters. My youngest graduates from college this Friday, so I'm excited. And obviously, as a legislator, a lot of what I've dealt with and prioritized have been family issues. Took us 6 years to get an extension of autism treatment through the system. I worked with a number of autism providers throughout the state of California to fight for autistic children to be able to have more than one option for treatment and benefit. And so the governor, after 6 years and after I think 4 or 5 vetoes, we were able to get that through. And so SB 805 was signed into law. And so now families have more options for bona fide healthcare options for their autistic children. We've been working on prescription drugs to try to help make those prescription drugs more cost affordable for families. SB 8786 deals with the middlemen, the pharmacy benefit managers, and trying to make it sure that the rebates get to people and benefit people. I tragically lost an older brother to suicide, and so behavioral health issues have been also very important to me, and was able to get SB 14 signed into law, which ensures that student absences for behavioral health issues are treated the same as physical absences. Think about that. If you had a sprained ankle, that was an approved absence, but if you were home with anxiety or depression, that was not considered an approved reason to be home. And so behavioral health and physical health are going to be treated the same way by schools going forward. The other thing is that we know our young people are great advocates for themselves. We know young people. One of the observations, my kids are 10 years apart. And one of the things I've seen in today's young people is they're very nurturing and caring of their peers. They look out for each other far more than past generations. Again, I don't have any hard data to verify that, but it seems like, for my observation, they're much more nurturing. And so we've been working to try to create a behavioral health curriculum for students, for high school and middle school students to learn about behavioral health. So as they advocate for themselves and each other, they're armed with more fact-based curriculum to back up their inner desire to help one another. And so that's also been signed into law. The parents of fetal alcohol children, many of whom have gone into different foster care and other adoptions and other things, came to me and said there was no IEP, individualized education plan, specifically for students with fetal alcohol syndrome. So we created a specific designation, because those kids were only getting services if they were on other disorders, not because of the one that they actually had. So they weren't getting the right care. And so those are some of the bills that we've gotten through the system. This year, we're working to expand access to Narcan on our campuses to make sure that kids, the opioid epidemic is tragic beyond belief. And again, if we can make sure that Narcan, which is, helps in those overdose situations, is readily available on campuses, and let kids carry them. A lot of kids ingest things that they don't even know what they are. And so we want to make sure that testing strips are more available. That was a suggestion from an intern in my office to make the testing strips more available. And so we're working to make sure that kids can carry those on campuses. The AIDS epidemic, somebody said yesterday, they didn't realize that HIV is still as prevalent as it is. And so we're working with advocates on making sure that PrEP and PEP medications are available to help prevent the spread of HIV. Obviously, it was World AIDS Day recently, and so we want to make sure that everybody's tested, know your status. That's the single best thing to keep the spread of HIV, is knowing one's status, so you can practice good behaviors and good practices. And so, as I've said, what affects families, what affects kids has been the top priority of mine. We increase funding for special needs students. This year, the budget is going to be a challenge. Obviously, many of you have read about the budget challenges. And so we're hoping that education doesn't suffer. We're hoping that the governor and the leadership negotiate on making sure the cuts are as palatable as possible and don't impact important programs. Unfortunately, there is a deficit in the budget this year, and so we're all prioritizing. Feel free to share your thoughts and perspectives on the budget with me or my office as the negotiations, once the May revise comes out. Overall, the state has been very committed to extending healthcare to as many people as possible. The rollout of the Affordable Care Act in California was the Cadillac of states. We know that the way we implement it here has been a remarkable model, and we want to continue to improve the Affordable Care Act in California. So again, if anybody has nuances they want to share with my office, I hope they do. We've tried to create as much access to benefits as possible. I just was at a press conference and we talked about how for striking workers, we've extended their medical benefits during those strikes. in prior legislation as a legislature. And so what touches one of us touches all of us. And I appreciate the opportunity to be here to share some thoughts and some of the accomplishments. People say, you do some small things. And I always come back to what Mother Teresa says, when they tell me my efforts are but a drop in the ocean, I say, isn't the ocean better off for that drop? And so when we do autism that helps one person, that helps another person, that helps another person, and it helps a family. And so I never look at how big an impact. We just want to make a positive impact for each other as we move the ball forward in California. So thank you for the opportunity to let me share a little bit with you this morning.
Thank you so much, Senator. And we appreciate you taking the time out of your day. I know you're extremely busy, especially with the budget, and Family Voices collaborated with multiple organizations to do the disco at the Capitol 2 weeks ago. And so we were all up there. Everyone saw us. There were about 400 to 500 self-advocates, parents, consumers that came up, and it was a great way for everyone to go ahead and not only meet with their legislators, but make sure that their voices were heard in regards.
If I could interject, people ask me all the time, is it worthwhile to come to the Capitol? And I say, absolutely. It is so critical to meet with your legislators, to interact with people, to get to know them, get their contact information, learn who their key people are, advocate. This is not a business for shy. I'm seeing a lot of the comments in the chat. We need to, what affects one of us affects all of us. And, this is a democratic process and a representative process. And, getting active and involved is critical to the success of the state of California.
Absolutely. And I know this was marked as a keynote, but I wanted to ask you, I guess, a furtherance of what you just said, which I think is extremely important. When we take people to the Capitol to meet their legislators, one of the biggest things that we hear from people, because we set up, I think it was 56 individual meetings with, around 600 people. So it was a large labor of love. And most of the time, assembly members, senators, obviously you're all very busy. You have committee meetings, you have things that you need to do. And so parents or consumers end up meeting with staff. Could you explain how important it is, even meeting with staff, and how staff conveys information back to, say, your office or just the legislature in general?
Well, I would say two things. One, when you see that legislator in the district, express your disappointment that they didn't take the time to meet with you. That's number one. I mean, obviously, if they're in committee, if they have they're running around, it's not a bad thing to express that. I mean, so for example, I was in committee yesterday, and when I had meetings scheduled, and I had my staff bring those people down to the committee room so I could at least show them the respect, look them in the eye, and thank them for being, taking time out of their busy day to be there. And so that's not, an unreasonable request for members to say, hey, if I could say hi to the member, I'd appreciate it, or express your feelings about not being able to see them. Now, to the second point, it is just as important to establish a relationship with the staff as well. And so that is critical too, because, the staff ends up doing, the lion's share of the work. And so having a direct rapport with the key policy people on a member staff is critical. And so I wouldn't say meeting with the staff is not as important, because in many respects, you're dealing with the actual person who's working on that issue that you care about. And so that's critical. So you want to do both. You want to establish a rapport with the staff, but you also want to hold the member accountable because they work for you. They're your representative. And so you want both. But I would not say meeting with the staff is not a good thing either, because they're the ones who are, when I meet with people, oftentimes I'll say, oh, and so, make sure you talk to my staffer on that. and I introduce them. So it's critical to do both. Have a relationship directly with the member, and then establish the direct professional relationship with the staff working on those policy issues is just as critical. By the way, you mentioned Keynote. I prefer the conversation. I don't like giving speeches. I prefer conversations. So I'm happy to stay on as long as my time allots if you have other questions.
Well, and I appreciate that. And again, I think that's a great answer, because when we were setting up all of our meetings, we had consumers and parents that were not upset, but perturbed, saying, why couldn't we meet directly with the legislators? And again, when you're setting up a large event, making sure that people are being able to advocate directly, we always say, especially within the systematic change, that making sure that you're connecting with someone from the office is extremely powerful, because then it leads
Absolutely.
to making your voice heard.
Yeah, and there are legitimate reasons for members to miss meetings. I mean, if they have a caucus meeting, if they're in committee, if they're negotiating, I mean, there are legitimate reasons for members not to miss a meeting that's been scheduled, because oftentimes you schedule these meetings a month before you come up, and we don't know what our day-to-day schedule is. All I'm saying is, don't devalue the meeting with the staff, but also then try to put a premium on meeting the member as well, whether that's in the district or you can always say to their schedule, hey, is there any way he can step out of committee just to say hi to my people? And again, most members will do that if prodded.
Absolutely. And I think that's, you put a pin in it, which again, it's just making sure that everyone knows that we were here, right? And
Right,
we were here,
exactly.
and we want to make sure that our voice was heard. And again, within Family Voices of California, and another project that we have, which is Project Leadership, where we go ahead and we teach, parents, professionals how to build their story to be able to tell their legislators and work towards systematic change. I was wondering on your end, what you think, because most people, when we talk, I have 2 children with developmental disabilities, and I can't get to Sacramento all the time. I live in the Central Valley. But I also go ahead and connect with my local legislators here, whether it be at the county level, or I speak at a school board meeting, or I'm there at our community advisory committees. Could you talk a little bit about how, because it is difficult for a lot of us to, say, travel with our children or take time off of work to get to Sacramento, how important it is to advocate at the local level as well?
Well, again, we all have district offices. We have district staff. We have different field representatives that represent us both in geographic areas and in policy areas. And so getting to know who your representative is in your particular city for your senator and your assembly member is critical, because they're a direct conduit to that member. And again, my district staff, they're assigned cities, but then they're also assigned policy areas. And so get to know those folks, be opportunistic as well. If the Kiwanis Club is having a pancake breakfast, chances are somebody from that district office is going to be at that pancake breakfast. If there's a state of the city address at one of the cities, and, all the staffs and politicians attend those public events. And so, meeting and establishing those personal relationships are important. The other thing is, even though we use Zoom, during the COVID crisis, I'm still doing Zoom conversations. I'm still, when people request a meeting with me, oftentimes it's at a day where I'm not in town, and I'll agree to do a Zoom meeting. So, always make that as an don't insist that it has to be in person. Give the legislative office the scheduling flexibility to consider doing it via Zoom, because you might have more success. Same thing on time. I mean, I'm happy to do a Zoom meeting at 8 p.m. when on a Tuesday night in the Capitol, because that's when I have free time. And so if you're flexible on the time, if you're flexible on the medium of the opportunity, you'll have more success getting those meetings with the members, and then meeting their staff in the district. So when you do write a letter to that legislator, their staff says, oh, that's Joe or Mary, I met them at the Kiwanis breakfast, and they seem like a nice person. The more repetition you have, again, politely and germane to whatever the subject matter is, the better reaction you have.
No, absolutely. And I appreciate you taking the time. And I know we have some questions in the Q&A, and I don't believe we're going to be able to get to all of them, but I assure you, I will be sending them to the senator's office to go ahead and get a response, and then I'll be sending them back. But one of them that I see here that, again, kind of pulls on the vein of what we're talking about in general is, how can parents or self-advocates make a visit more impactful for you? Or give some examples in regards to speaking to district offices versus capital offices. How do parents make an impact, or how do consumers make an impact when they're meeting with your office to make it something where you walk away and go, wow, that's something that, again, obviously you're already involved heavily with the majority of the issues that we're talking about, and our target audience, which is children and youth with special healthcare needs and intellectual disabilities. But are there any examples that you have of things that have really caught your attention, or things that people have done where they have, really pierced through your staff, to where their staff comes to you and says, hey, we need to talk about this? Is there anything they can do?
Well, I think one of the things that always hits home with me is when parents share family photos with me.
Uh-oh, Senator, I think you've lost your audio.
I said,
Thank
one of
you.
the things that always impacts me is when I get to see a family photo. When you show me a picture of your child, that as a parent, that always hits home. And so sharing your personal story, sharing a picture of your child, you know, has an impact with most of us. And the same thing with staff. I would, follow up a meeting with a personal note. Again, another touch to that person in a timely manner. You know, repetition. I mean, oftentimes I see the same people, who come on every year, and I get to commiserate with them. Folks who come to the Capitol will then follow up in the district with me. And as you mentioned too, I mean, I also recognize that we all have busy lives, and the parents have lots of challenges in their own household. So, don't feel pressure that you have to do any of this stuff. Do what you're able to do in the manner in which you're able to do it, and feel good about it. And know that others are also doing it. That's the other thing: strength in numbers. If you can't make a meeting, someone else is going to make a meeting. If you can't make a Zoom call, someone else. Don't put so much pressure on yourself. And I think in many respects, if you take pressure off yourself, the interactions you have are going to be much more positive, because they'll be more relaxed. I think that's the other thing people need to realize, that we're no different or better than anybody else. And so be relaxed and passionate.
Absolutely. And I appreciate that. And Senator, I appreciate the fact that you took the time out of your busy schedule to address, the family members within the state of California, and the providers, and all the different demographics that we have here. I know that you have to go and present a bill, so you need to be off. But again, on behalf of Family Voices, we appreciate the fact that you took the time and your insights. And again, keep up with the good work, and we look forward to hearing from you in the future.
All right, my friend, be well, and everybody take care. God bless. And as I always say, hug each other and love each other, and be well. Take care.
Thank you, Senator.
Bye-bye.
All right. Well, that was fantastic. And again, we apologize for the delays in certain things. Again, the senator had a press conference beforehand, and we had a lot of things going on during that time, and now he has to go present a bill. So I think we did okay. And again, I saw all of your questions. I absolutely will be taking those and presenting those to his staff so that they can get back to me. All of this is recorded, so I'll be able to go ahead and send those messages and those answers from the staff directly back to you so that way you don't feel as though you weren't heard, because I promise you were. And with that, again, such a great opportunity to be able to have the senator here. But we have another great opportunity as well. We're going to talk about a system called CCS. And I'd love to introduce, and again, I thank her so much for being here. I want to introduce Ann Kuntz, who's the president of this and CEO of the California Children's Hospital Association, to go ahead and talk about California Children's Services. Ann, take it away.
Thank you, Nick. It's really my pleasure to be here this morning with you today. I'm not only the president and CEO of the California Children's Hospital Association, as Nick mentioned, I'm also the parent of a child with special needs. So this is really, I feel I'm with my my home crowd here. So today, our plenary session is devoted to an overview of the California Children's Services Program, which is also called, colloquially, we call it CCS. Our panel this morning will be covering some of the important initiatives being undertaken at the state and county level that are intended to improve the operation and oversight of the program, as well as providing some advice from knowledgeable parent advocates about how they've navigated CCS for their children. If I could ask our panelists to turn on their cameras for a moment, I'm going to introduce each of them. So joining me today for this discussion are Courtney Maslin, who is the chief of the Integrated Systems of Care Division at the Department of Healthcare Services, Lael Lambert, who is the Nursing Services Manager for Marin County's Family Health Programs, Monica Toma, who is a Community Navigator and Parent Consultant for Rowell Family Empowerment and the parent of a child with special needs, and Nancy Netherland, who is the mother of and advocate for her two daughters, both of whom are living with rare chronic medical complexities. Each of our panelists will speak for 10 to 15 minutes, and then we'll take questions at the end. If you have questions you'd like to ask as we go along, click on the box at the bottom of your screen that says Q&A, and then type your question into the text box. We'll read them out and do our best to answer them at the end of the panel presentations. To start us off, I'm going to give a brief description of what makes the CCS program so unique. Can we move to the next slide? So the California Children's Services Program, or CCS as it's commonly referred to, provides life-saving medical care, specialized case management, and support services to about 208,000 children with complex medical needs across the state. The program was founded in 1927 as a result of the polio epidemic, but eligibility for the program has grown over the past nearly 100 years to include other life-threatening conditions like cancer, sickle cell disease, cystic fibrosis, and neurological complications from extreme prematurity. In order to be eligible for CCS, a child must meet certain criteria, including having a diagnosis for CCS-covered medical condition. The child's family must also meet current financial eligibility for the program, which for the most part means the child must be eligible for Medi-Cal, or the cost of the child's medical care must exceed 20% of their family's adjusted gross income. One of the unique benefits of the program is that it sets clinical guidelines and standards that doctors, hospitals, and other clinical staff must meet in order to participate in the program. These standards help to improve care for all children with special healthcare needs, even those who aren't eligible for CCS. The program is run by the Department of Healthcare Services in partnership with county public health departments. It's truly a one-of-a-kind program in the country that is designed to ensure that children with complex, life-threatening health conditions can obtain the medical care and support services they need to grow and thrive. Next slide. Historically, the CCS program has been run separately from managed care, and particularly Medi-Cal managed care. So historically, if a child in the CCS program was also eligible for Medi-Cal, their routine primary care would be overseen and arranged for by their Medi-Cal managed care plan, while their CCS care would be overseen and arranged for by the CCS program, either at the county or the state level. But recently, the state has implemented a transition in some counties that puts the responsibility for arranging CCS care with Medi-Cal managed care plans. This is referred to as the whole child model. The map on this slide shows where the whole child model operates now. You can see that in the sort of purple colored counties. And then if you look at what's the green counties, those are the counties that will be transitioning to the whole child model in 2025. And then those counties that you see in kind of an orange color are those counties that'll remain in what's called the Classic CCS model, where the county or the state will continue arranging for CCS care, and Medi-Cal managed care will continue doing the primary care. So that's a brief background. I kind of added a slide about the whole child model because we're going to spend some time talking about it this morning, and then later I think there's a breakout session on this, kind of the same topic. So I just wanted to give that brief overview about where things stand today. But now I'd like to turn the mic over to Courtney Maslin, who will discuss a few of the initiatives that DHCS is working on. Courtney?
Thanks, Anne, and thanks to Family Voices for having the Department of Healthcare Services to present on this important issue. Next slide, please. So I'm going to speak about a few things with the time I have, and really want to have this as an opportunity to have a discussion and have some time for questions and answers. So I keep some of my updates brief, but really focusing on California Children's Services enrollment, what we're doing for CCS performance measures and ongoing monitoring of both the whole child model and classic delivery systems, and then some updates about the 2025 whole child model implementation and lessons learned from previous implementation. So I think that's all that I have as a slide deck. So I'm going to really speak to what we've been looking at in terms of ensuring that the program continues to be monitored for enrollment and referrals. We, of course, have some changes because of the Medi-Cal redeterminations re-beginning after the public health emergency and doing those annual redeterminations as well. So we're committed to ensuring that, we're monitoring this. We post on a monthly basis information regarding enrollment trends and are really diving into where are people falling off the program, in the sense of, are they moving from the Medi-Cal CCS program to the CCS only, which, as Anne mentioned, is where it's based on financial eligibility of the family, and really ensuring that no one's actively being disenrolled or losing coverage because of some administrative errors. So really looking into that. Unfortunately, I don't have all the things to report on that. But just want to know that there's a commitment to looking at that. In addition, when the public health emergency ended, we sent information to all families and members regarding this restart of annual redeterminations, and really trying to educate families and members on the fact that there's a Medi-Cal redetermination and a CCS redetermination. Sometimes they're in the same month and sometimes they're in different months. So just wanted to continue to put the word out that those are really key, because unlike the past preceding 4 years, that is re-beginning, and that's where you're going to be submitting your new medical information, your new residential and financial information to the county, working with your case manager to make sure that you remain on the CCS program because of all the benefits it provides. We can say that, there has been some trending down of CCS Medi-Cal enrollment, but we have also seen a trend upwards in that CCS only Medi-Cal only enrollment. So wanted to make sure to that. And then we all are always tracking that there's normal fluctuations in enrollment. And so we're really looking to make sure that the churn rate, or the rate of which people fall off of CCS for various reasons that are normal, we stay at around that churn rate pre-pandemic, which was about 2 to 3%. So really pulling monthly data, assessing, and working with counties where we're seeing that there is abnormalities is really what the department is doing at, and making sure that we're monitoring not just day-to-day operations, but those kind of larger issues to make sure that no one's losing coverage. They shouldn't be. Right now, our current enrollment figures are 180,442 statewide CCS Medi-Cal enrollees, and about 14,297 are in our CCS only program. So running around, 200,000 people in the CCS program, which is great. And just wanted to give some information on that. I know I'm talking probably pretty fast for the Spanish language interpreter, but so I'll start to slow down. Also wanted to talk about a lot of the work that we've been doing for monitoring quality and service delivery, really spending a lot of time in that space. I think there was a few things that have passed over the last few years in terms of changes to the CCS program, one of them being our CCS monitoring and oversight program. This is really focused on our classic counties and ensuring that we have a monitoring and oversight program for the CCS counties in terms of member focus as well as overall operations. So The implementation date of that effort will be July 1 of 2025. However, in the meantime, we're going to be doing a few things and working with the counties. And the counties will receive funding for some of this effort. And one of the biggest things that I think I would want to call out to this group is we were going to have a formal grievance process. This grievance process would be in addition to, if you are a Medi-Cal member, the Medi-Cal managed care grievance process. But this is really focused on concerns you have maybe with the CCS program, the CCS county, or other things. And so this is an opportunity to file a grievance. We have grievance and appeal fact sheets that are member facing. So these are great resources for families and members. We'll be getting that over to Family Voices, but it's currently posted on the Department of Healthcare Services website. And we will be able to get that out to this group as well. And that's really a way for, if you have a concern regarding a service authorization request, concerns getting equipment, supplies, things like that, that's an opportunity for you to, first of all, hopefully be able to resolve that with your case manager, but have an opportunity to also be able to file that so that we can be tracking those issues at the state level. Additionally, this will also implement a process for things like surveys of the counties in subsequent years, so starting in a later date, as well as having some other opportunities to really get reporting from the counties to see if there's any trends that the state needs to address. Another requirement that we've been tasked with is doing some, reporting and transparency for both Classic CCS and our whole child model delivery systems. We really want to make sure that CCS care is high quality, regardless of what county you live in and what system you're getting the care delivered in. So there's a few things we're going to be doing. First is we're going to be posting more information to our Department of Healthcare Services website regarding performance on different aspects. We already have what we call the CCS Whole Child Model Integrated Dashboard, which is a great data set that includes things like enrollment figures, utilization of emergency room visits, number of grievances and other things. And so that is a great starting point. But through this effort, as a result of Assembly Bill 118, we are going to continue to build off that and really start to get to some granularity regarding utilization of special care centers, because really we want to make sure that the people in the CCS program are getting the right care at the right place, right? So that'll give us an opportunity to assess that. It'll also give us an opportunity to start creating some benchmarks, right? Some quality measurements. What I mean when I say quality measurements is data that we get at the department where we can see if a certain plan and or county might need some more technical assistance, a quality improvement plan to ensure that care is being delivered in a timely manner, right? So some things we want a high performance level and some things we want a lower performance level, in the sense of a lower percentage is better, and in some cases a higher percentage is better. So some things that we are looking towards doing is, emergency department visits tied to the CCS eligible condition, right? So we want to see, are there, there could be a reason for emergency department visit, but we want to see kind of, is there a standard that's happening statewide, and how much of that is tied to CCS eligible condition and how much of it is, if a certain percentage is about normal. Also, inpatient admissions. We know that CCS people have complex conditions, but we want to make sure that these inpatient admissions, that there's a standard norm, and then if there's any outliers, providing technical assistance either to that managed care plan or that county as necessary. This also, things like special care center visits is really important, which is making sure that there's referrals to special care center visits upon entry into the CCS program. We want to make sure that people are getting that referral within 90 days. We know appointment scheduling can take a while, right? There's different things, maybe even, the family needs additional time to work on transportation or, time off, especially if they're going to a special care center that is far from their home. And so we are going to be looking at that. And then we're also really looking to see what other things we should measure. So we've been working with a work group since August 17th. I'm happy to report that we have great representation of the subcommittee members, including providers at special care centers. We also have county representatives, whole child model plan representatives, family representatives, as well as other interested stakeholders and advocates that can provide the perspective of what we should be measuring. This and that this is a result of that. And so these are all things we're working for to a January 1, 2025 implementation. And so that's where the dashboard will show data from that year, as well as the quality measurements the reporting will be in that year, and we'll be able to assess it in 2026. So I know this seems like a far way away, but these are all great things to make sure that the care is being delivered, and we have these checkpoints to reassess and reevaluate. The next meeting on that quality measures is open to the public, and it's on May 30th. On our DHCS website, you can find the link for the webinar already. And then the meeting materials come at a later date. It is quite a dense meeting, but I think there are some great things that come out of it, right? We're hearing perspectives about what people want to see in this reporting and how that actually drives to evaluation and areas where we can assess. Because I think ultimately these are all steps in order to get to that point where we're monitoring and evaluating the CCS program, as we have been to some extent, but this really kind of solidifies it and gives us that guiding light. And then I have a lot about whole child models, so I'll try and keep it brief, seeing that there's another breakout session later today. But I have to give some facts and circumstances because I think this is mostly something that impacts maybe some of you on the call, whether you're our county partners, our plan partners, or our families, because this is something where, as Ann mentioned, is in quite a few counties this year. But I want to spend a little time talking about the 2024 implementation of Kaiser. So as of January 1, 2024, Kaiser implemented as an alternate whole child model plan in 8 counties: Marin, Napa, Orange, San Mateo, Santa Cruz, Solano, Sonoma, and Yolo. And so as a result of that, there were 2,618 CCS children that transitioned into Kaiser as a result of that. We, as a department, held monthly meetings with Kaiser that began early last year in 2023. And then the 8 counties were also engaged through planning meetings throughout the year. And we are making sure to meet with still some of these entities after the implementation to see how it's playing out. And I think we've received some valuable feedback that me and my team are considering of how to kind of work that into the 2025 implementation. Kaiser was required to submit information, what we call deliverables, so things like policies and procedures or clinical protocols to the department for a review and approval to ensure that they could take on the complexity of the CCS children. Those were reviewed and approved, and also we worked on the MOU execution. So a MOU is kind of an agreement between the county and the plan on how on various interfaces where they'll interact with one another on certain activities, things like CCS eligibility, which is a county responsibility, but that really ties into how Kaiser beneficiaries receive the program. So lots of work done there on coordination between the 2 entities because that's key. Additionally, we're looking at, we have been doing post-transitional monitoring. And so there is a reporting structure in which Kaiser lets us know about certain concerns they're having, and also reporting on how the transitioning members are kind of playing out in the sense of what kind of out-of-network access requests there are, continuity of care requests. So continuity of care is being able to see the same doctor for a year post the transition. And this is something where we're also looking for if they're working on contract negotiations with that provider, whether it be a special care center or a physician, to get them in network going forward. And those will continue throughout up until July, and if needed, ongoing. And they'll be at different intervals. So we started the first few weeks was weekly, then the first few months is then monthly, and then we moved to a quarterly reporting period. And then also a lot of work, as I mentioned, on ensuring that the provider network is meeting the needs of the clients that transition, right? So we did a lot of work with overlap of who's assigned to a special care center and what are Kaiser's actions to contract with those providers. And so, Encourage families to reach out to Kaiser if you're in Kaiser and have any of those concerns, because continuity of care can be requested still even a few months later, because maybe you don't see your clinician every month. And so maybe this is the first time you might be seeing that clinician. So definitely encourage, if you have any concerns, to reach out to Kaiser and to request continuity of care out-of-network access if needed. Also, as a result of Assembly Bill 118, there are some protections that were kind of put in place, and I think these really tie into, the transitioning of more kids into our managed care system for whole child model. So there'll be requirements to establish a primary point of contact responsible for the whole child model members' care coordination, similar, if you're in a classic county, to your case manager at the county level, right? To have that point of contact, that direct point of contact, not a phone tree, but someone you can call and have asked questions about. Also, this requirement will be implemented in the next year, and we're going to be issuing policy guidance on what that looks like to the whole child model plans. Okay, I know I'm talking really fast, but there's a lot. We're doing a lot. So in 2025, we have the expansion, as Ann mentioned. So I think really just want to call out the names and the plans that are involved in this. So I'll try and go slow. So there will be, in Partnership Health Plan will expand to be a whole child model plan in the following 10 counties: Butte, Colusa, Glenn, Nevada, Placer, Plumas, Sierra, Sutter, Tama, and Yuba. Additionally, Central California Alliance for Health, which is on the Central Coast, will expand into 2 new counties, Mariposa and San Benito. And then also, in addition, Kaiser will be an alternate health plan, whole child model plan, in Mariposa, Placer, Sutter, and Yuba. I know that's a lot, but just wanted to kind of put out that there's going to be some transitions. All of these Partnership and Central California Alliance for Health have been whole child model plans since 2018. And so they do have expertise, but we also know there's regional differences, right? These are, rural counties, and that a lot of them don't have special care centers or have limited special care centers. So we're, of course, looking at network and readiness with fresh eyes, right? So I think that's one thing I want to say. So similar to Kaiser, they will have requirements to submit deliverables, policies and procedures, and network readiness documents. I think the key is that network readiness, because really that's where we're building out their special care center networks in that location and regionally. And so I think one of the things is not every county has special care centers. So there are requirements to ensure that there is either at least a regional or statewide network of those subspecialists and special care centers. So as we said, there's going to be a lot of readiness activities that the state does. I think most notably is, reviewing and working with Partnership, Central California Alliance for Health, and Kaiser to build out their ability to take on these clients. But also, I think the biggest thing is really that member notification piece, right? So we are the ones that develop the letters that go out to families, and then what we call a notice of additional information. It's really more of an FAQ style document, a frequently asked questions style document, to talk about how this really impacts families and what questions they should be addressing and answering in advance of the transition. So there are 90-day notices, 60-day notices, and 30-day notices. They will be similar to how we mail out other Medi-Cal notices, right? Because the only kids that will be transitioning are ones that have Medi-Cal. If they are CCS only, they will continue to be under the oversight of the county, or there might be a few that are in fee-for-service, and those will remain with the county as well. And so this information will be shared has already been shared with stakeholders who have given us valuable feedback. And we have incorporated that and are still going through the final review before we share with the plans in advance of the 90, 60, and 30 days. Also, we have there's a lot of things that we need to do that impact the families indirectly, right? So things like provider noticing, making sure our CCS panel providers are aware of this change. I know Anne and others on this call are really helping us get the word out, but we really want to make sure that we're not missing anyone. So there'll be provider noticing around September, October to advise them of the notice. This will have changes to how they bill, and how they provide services and where they send the authorizations to. So this is key to ensure that there's no delays in cares post the transition. As I mentioned before, we will have similar post-transitional monitoring. And so I just want to acknowledge that, this is a key aspect, but really I think the biggest things that we're trying to verify with this effort is, do the plans have the network needed to serve the clients? And do they have the expertise to operationalize the program? And so I know that's a lot, but I think I want to make sure that we have time for my other partners on the call, as well as a time for question and answer. So I will turn it back to you, Anne.
Thank you, Courtney. There's a bunch of questions in the chat. I'm not going to go through them right now. I just want to make sure, Courtney, that you can stick around till the end so that because some of them I think will be things that you and I will have to work out, having to do with like my different number from yours and a couple other things. So are you going to be able to stick around till the very end?
Oh, yes, I'll be here.
Okay, excellent. All right, so we'll get to those questions later. Thank you for everybody. I want to encourage people to keep putting your questions in the chat, in the Q&A, not in the chat, because I'm not checking the chat, but I am checking the Q&A. So I'm going to turn it over next to Lyle Lambert, who is the Nursing Services Manager for Family Health Programs in Marin County. Lyle?
Hi, thank you for having me. I appreciate being here. My name is Leah Lambert, as Anne has said, and I am the CCS administrator for Marin. Marin CCS is a whole child model county that transitioned in 2019 with Partnership Healthcare of California. And then we added Kaiser Permanente as of January 2024. I'm a part of many collaboratives in implementing the whole child model in my county as well as other counties. I'm a part of the whole child model state subcommittee. I'm a part of the partnership whole child model collaborative, and I'm a part of the 8-county Kaiser managed care plan. So we've learned a lot. We've learned a lot together in the last 6 years. And some of the things that we as this collaborative are working on is revised MOUs with the plans, identifying and developing recommendations to ensure children receive the right services at the right time by the right provider in the whole child model, and incorporating the expanding counties into whole child model in 2025. We really believe that us working together makes a stronger collaborative and has a better outcomes. So I'm representing the whole child model counties and bring our combined knowledge that we've learned for the last 6 years. Next slide. So some of the things that we've learned from the whole child model implementation currently are the focus is the child. The focus is the child that needs the CCS services. And I just want to highlight that the original intent of the CCS program was to provide necessary medical services to children with CCS eligible conditions, whose parents are able to pay wholly or in part to get healthcare and services they need. The whole child model was expanding this services for CCS kids to receive a focus on whole child model, including children's full range of needs rather than just the CCS condition. So in whole child model counties, case management's been assigned to the plans, and the whole child model case management includes comprehensive treatment and case management for primary, specialty, and behavioral health services for both the CCS condition and the non-CCS condition. We think that's really important and elevates the level of services for kids depending on how it's implemented. Courtney referred to SB 586, which requires whole child model plans, managed care plans, to maintain or exceed the CCS program standards and access to specialty care. It also says that it should provide continuity of care and access to expert CCS dedicated medical case management, provider referrals, and service authorizations. Those are all now the managed care plan's responsibility. I think many of us in the counties, many of the advocates thought that when SB 586 was implemented, that plans would employ staff with CCS or pediatric experience, and that they would continue to provide case management as typically had been seen by the CCS programs, which is with a case manager familiar with CCS medical conditions and the needs of the individual child and their families. What we found is plans, by comparison, appear to operate more as a client-driven model. This means that when families call to request services, plans fill the need and close the event. Plans are required to provide a comprehensive assessment for each child as they enter whole child model. And then when the families need resources, they call member services and are transferred to a care coordination team or the team that manages that service, for example, M&T, maintenance and transportation. As you heard, Courtney and the state DHCS are working on how this can be reinforced and supported in a stronger way. Most the times when members are connected, when families call member services, they're connected to a navigator who will help them connect to the requested services. But we're not seeing proactive medical case management, which is the normal practice in CCS. So I can see where that is a bit of a difficulty for families and kids getting their services. The plan and the level of staff, their experience, all impact the level of services that kids get and their families are able to receive. In my experience and discussions with counties, managed care plans, and DHCS, the terms we use and the family the terms we use and even the simplest terms have very different meanings. How it's interpreted, it really makes a difference. So words and definitions are important. That's another lesson we learned. There continues to be a great difference in how managed care plans, counties, and ISCD use the simplest words. Words like refer, open, case management. Now, after 6 years of experience, we know these terms aren't really simple. They just seem like it. Not only are the systems different, between managed care, the state, and the counties, there's also a huge turnover in staff in all of these systems, the counties, the state, and the managed care plans. Since 2018, as Courtney and Ann both have talked about, we had 5 managed care plans with 21 counties. In 2024, we added 8 of the 21 counties became whole child model with partnership with Kaiser as a whole child model and managed care plan. And in 2025, there'll be three of the existing managed care plans will have an additional 12 counties. This is complicated. This is, how we interpret the words and how each of us implements it really makes a difference for you as the families. And we really focus on how do we ensure that we get the kids to the services. I want to emphasize Kaiser has always been a really strong healthcare provider. They provide medical care and have a long history in California, and they've been a health plan. But now they're entering this arena as a managed care plan, which is different. So I just want to emphasize here, we have another difference. I want to also give one example of a difference in terms. Referrals, which seems like an easy word, simple word. The data has indicated that there's a decline in referrals, somewhere about 27 to 36% of referrals in whole child model counties, while in average classic counties, during the same time frame, there's an increase of 28%. So there's something about referrals that is impacting enrollment, impacting us getting the referrals and the kids getting the care. The data reflects that there's a different interpretation in the referral and the process in which managed care plans and providers are hearing that process. In classic counties, most of you know CCS accepts referrals from any source, and in the whole child model, there have been different processes, different understandings, and different rules. This mirrors and it likely causes a significant decline in case loads in the whole child model counties. And it was reflected that UCSF whole child model evaluation found a statistically significant decrease in whole child model enrollment in whole child model counties in CCS. I'm sorry. UCSF whole child model evaluation found a statistically significant decrease in CCS enrollment in whole child models compared to classic counties. We in whole child model counties, both current and expanding counties, continue to work with the managed care plans with DHCS to come to agreement on terms, definitions, processes, and in support of the children getting the care they need. We know that the best solutions are when we identify these issues, have written resolutions, and a space to resolve discrepancies. Next slide. So how have we been working with DHCS in transition to whole child model? DHCS continues to meet with many groups of counties in different configurations. We have 21 whole child model counties that meet with the DHCS. We have 8 current whole child model counties that meet regarding Kaiser. We have 12 transitioning whole child model counties, and some of those have Kaiser counties. We have CCS bi-monthly meetings, CCS AG meetings, CCS exec meetings. We have a lot of meetings. And DHCS is holding managed care plans and counties accountable for submitting readiness deliverables and the need to come together in common agreement regarding the definitions, but we still have a ways to go. Managed care plans are also, counties are also meeting with managed care plans consistently to discuss this transition. Despite all these meetings, there continues to be confusion about some of the same themes, with a lack of consistent understanding, a lack of root cause of the problem, and a lack of tracking and resolution of the issues. We as CCS counties are committed to supporting the evolution of CCS and whole child model, ensuring that the kids remain the focus of the care. Next slide. The expansion of whole child model has highlighted in 2025 has highlighted on many of these unresolved issues, and the expanding counties are struggling with the hyperleap from classic CCS to being a managed care plan to implementing whole child model in 2025. Some of the issues that still need to be addressed is terms needed to be defined in writing with agreement of what that means for some of the simple terms: case management, referrals, continuity of care, and point of contact. Our challenge as CCS and whole child model counties is to correlate the issues by trends and by numbers, action, and develop action steps into solutions. We really need to clarify regarding who is the authority and the decision maker and what's the process when there's a disagreement with plans and counties. And we need to continue to advocate for a method for CCS specific indicators to evaluate care that kids receive in the whole child model. That is concluding my presentation. Thank you for your support and continued commitment for the kids in California. They are our future, and we continue to ensure we work together to continue that they get the benefits that they deserve. Thanks.
Thanks, Lael. I really appreciate it. I next want to turn to our first of our parent advocates to hear their perspective. So Monica, I'm going to turn it over to you.
Thank you so much, Anne. Good morning, everyone. I'm glad to be here today with all of you. It's an honor to be here and sharing this time with families and with professionals that help get my son where he is today. So I just appreciate sharing this time with you and collaborating and just being here to share and hopefully help others. Is my heart today, is to do that. So I do work here at Ralph Family Empowerment, and the reason why I'm here is because of my son. And He's now 24 years old, or he's soon going to be 24 years old. He reminds me his birthday's coming up, and he's reminding me of what he'd like for his birthday, cheesecake and the tour of Italy. So he's very good about advocating for himself on that front. But we started with the California Children's Services early on when he was 4, and he had it up until age 21. And so I'm blessed because he has taught me everything I know. I have traveled, I have been to school, and I've learned more from him in these years. And so I bring all of what he's taught me to Rao Family Empowerment and help many families to help them on their journey with California Children's Services and all the other services that families receive while they're navigating through the system. So next slide, please. So here is a picture, a little bit of our journey, and I'm going to start in the right-hand bottom corner. That's our little Alex, far from being almost 24. He's just a day old in that picture. And as a parent navigating through this system, it was quite an interesting process. As it started out, his APGAR score in the hospital was a 9. My husband and I had no idea what was ahead on our road. And I'm so thankful for the services that were there as he was growing and developing. I do have a background in early childhood. And thankfully I did, because I could see that he wasn't meeting and reaching milestones. And that was to me a first indicator of, I think we need to reach out here and get some referrals and find out what's going on. And so in the next picture, I'm going to go to the top left-hand corner, and that is him and learning to eat. He could not breastfeed, and so we had to find another way to feed him, and that was he has low tone in his oral area. And that's a Haberman feeder. Some of you may be familiar with a Haberman feeder. It helps him get the nourishment in the food without having little bubbles in his tummy. And so that helped him get the nourishment, but he could not do the suck, breathe, swallow synchronicity that was required for breastfeeding. And so we had to figure out another way to get him nourished. The bottom left-hand picture is him getting ready to, be sitting up. You can see he's got some low tone in his trunk there a little bit, and learning to be sitting up. You see that hand right behind him, ready to catch him as he's kind of wobbly. So we had to work with him on building up those trunk muscles as he was growing. I want to first, before I say what our son's diagnoses are, I want to first say that to families that are out there and listening, and no matter where you are on your journey, that the diagnosis don't define fully who your child is. And that took me a while to understand that. It's part of who they are, but the heart of who our children are the beautiful things that you see coming out from who they are and their gifts and talents. So for example, my son loves Legos. He loves animals. He has got a wonderful sense of humor. He's actually very social. And so he was given diagnoses of autism, polymicrogyria, which is many small folds in the frontal lobe of his brain, which it affects executive functioning. So the planning, the organizing, the prioritizing part of the brain was very much affected there. He has cerebral palsy, low tone, ADHD, OCD, and hard of hearing. So he got quite a bit, and the diagnoses were helpful because it helped get us services in the community. But there's so much beauty within our children, and the person-centered plan is what helped us identify that early on. We started with a poster in his room of all the things he did well so that he could see it every day, and we added to it as he grew and developed. The right top picture is, I'm going to say, a glory moment for me as a mother. It's one of them that I'm going to share with you today. And this wasn't a local event, which inclusion is so important for our children, getting them into the community. And this was Night to Shine with Tim Tebow, where it was at one of our local churches where our children get to walk or run on a red carpet. They get to be a princess or prince for the night. they get to have a meal with other people. And the lady that you see sitting next to him, my son was probably about 18 or 19 in this picture, is a California Children's Services employee. And she volunteered to be with my son and to share this evening so he could have the support he needed. He tends to eat quickly, and so he has a risk of choking. And so she was his physical therapist and worked very well with him to help him transition. Again, on the spectrum, he has transitional difficulty, but she was there to help guide him through the night. And I'm so thankful for that as a mother, to have those people in our children's path that want to step up and say, I want to be there for your child. That didn't happen a lot. So as a mother, I'm very thankful for that. So just looking at this picture, as a mother, I asked the team there at the church, I said, can I just stand against the wall? I just need to stand against the wall for the evening, and I need to watch my son. After, 19 years of hard work, of being on an IEP, of getting behavioral support services, of getting Far Northern Regional Center services, of getting California Children's Services, of getting in-home support services in our home, of getting respite, of getting socialized academic, social experiences, social and emotional training because of the autism to help him learn how to interact with others. I had to stand against the wall and just watch him. And it just did more justice for me than a picture could do, because I got to see it in live time. So I watched. And I saw him sitting at the table. I saw him looking in the eyes of other people. I saw him picking up a fork. 5 years it took as a mother to teach him that fine motor of picking up that fork, of then putting the food in his mouth and knowing how to chew. Learning to chew it took 4 years for me to teach him. I had to go to a special therapist so that he could learn how to chew his food. To sit up straight, to get the physical therapy to be able to sit up straight, to be able to walk appropriately without tripping. All of these things coming together to be able to wait his turn in a conversation that I got to see and just relish the moment as a mother, and just feel blessed that all of these services helped him be where he is today. So it's very important. I just want to give out hope to parents. I don't know where you are on your journey, but here I am. Never thought I'd be here sharing this experience with you. But it makes us strong people, and it helps to have our voices out there in our community for our legislation, because we've been through it and we can help so many people, and it just helps carry that voice. So I just want to encourage families that are listening today. And I just want to thank all the professionals that have helped in making this journey for us very pleasant and much easier. Next slide, please. So these are the services that we receive for our son. In starting with the occupational therapy, I did say he was on an IEP, an individualized education program, at age 3, and he ended his IEP at age 19. What we did when he was in high school, and we had an IEP team meeting about it, is we incorporated it was called the medical therapy unit when my son was younger in high school. And we put it in his IEP that he could leave at the end of the day when he wasn't, missing academic time, that we could go to his services. And so one of them was occupational therapy services. The other was the physical therapy services that he received. He worked in the kitchen. He learned life skills with the therapist. The physical therapist helped strengthen his right leg because he has the cerebral palsy affected the right side of his body more than the left. So we worked on that leg, and she gave us exercises to do so that we could work on those. And I am so thankful again for the guidance of all the therapists, because they are the ones that taught me and my husband how to integrate it day in and day out, is what it takes day in and day out for our children to grow and develop these areas that are difficult for them. So I'm so thankful for that guidance. we found out later that he was 90% hearing loss in his right ear. And it was my husband that figured that out. He was wearing a headset watching TV, and my husband took the sound out of each ear and he figured it out. So we followed through with that. And sure enough, he was put in a booth where they could do more of the deeper testing of the hearing. And so we got a hearing aid, and that was made possible because of California Children's Services so that he could hear. And I'll never forget the day he put that hearing aid in his ear, and oh my gosh, his life just opened up to what he could hear. Now he could hear everything. I can't get away with anything now. So it just opened up his world. And so we're very thankful for that. Also, the orthopedic supports. He had a shoe insert that went inside of his shoe because his right leg was a little bit shorter than the left leg, and he needed to learn how to straighten that right leg. So we got the shoe insert, and he needed to add a sole added to the bottom of his shoe to kind of bring up that so that he could be equal in his gait when he was walking. So all of those things really helped, and the therapies, it made it just a world of difference for our journey for us. Next slide, please. Well, I have to say this. My son loves Christmas. He loves holidays. And in fact, we get to hear Christmas music year round in our home, which is such a delight. We get to hear, Oh Holy Night and Jingle Bells year round. It's something he just loves. He loves to sit in his room, build Legos, and listen to Christmas music. And he actually went into eBay and got 100 CD set of Christmas music. And so I get to hear country Christian. I get to hear rock Christian. But he loves it. And CCS provides a wonderful holiday party with Santa Claus. And I'm so glad for these Santa Clauses because they're pretty hardy. My son, being on the spectrum, will say anything. And that filter sometimes isn't always there. And so I'm not embarrassed if there's a question asked of Santa. He's pretty hardy. He's been through a lot. And so he got a special gift. I know this California Children's Services employees heard what he liked. He had a special gift under the tree. As he got older, he wanted to help DJ the event. So he got to help sit up front with the music, and he got to help with the food. Of course, he loved the food. The cookies and the brownies are number one highlight for him. And just an opportunity for him to socialize with other families. He got to grow up with these families in our community, which inclusion is so important, and be around other people. And as a parent, I got to work and talk with other parents too. And we got to share our experiences and just be there to strengthen each other. So it's a great outlet for our children, and it's a great opportunity to get into the community. Next slide, please. I want to share just a little bit of what I went through as a mother. And I don't know if there's anybody today that's listening that is going through some of these things, but I wanted to be transparent and share kind of where I started as a mom. Having a child with all of the special needs that we received as he was growing was first for me. As a mother, how to deal with that journey emotionally, how to work through it, because now life is a little different now for us. And so how to adjust to that as a mother. So this picture, I felt depicted very well what I was going through. I felt like I was in a black hole in the beginning. I could see the light up there. You notice there isn't anybody else around me. The walls are cold. It's dark. I could see the light. I could see the ladder, but it's not going to the floor. How do I get up there? How do I get to be where I can be to be the best for my son and helping him grow and develop and be the best he can be in our community someday as an adult? So that's when I've realized that I need to get the services so that I could learn these things, as California Children's Services is one, the Far Northern Regional Center is another, and slowly each rung represents one of those agencies, and it will come to the floor. Then I can climb up that ladder, go to the light, and I can be fully there and equipped to working with my son when I have those skills. And there's a lot of learning involved just in special education alone. There's a lot of black and white, but there's a lot of gray in special education and learning and understanding that whole world. And then with California Children's Services and all of the things that are maybe needed for your child with fine motor, with gross motor, with, you know, the eating, with the occupational therapy, the sensory needs of the child, all of those things, getting the IHSS in-home support services. My husband left his job so that he could be home with our son. And so that's a big adjustment for families. And so I was thankful. We are so thankful for California and providing that so that my husband could be home and be there for our son, because he would be called and we'd have to pick him up from school. We had a behavior plan. We had a functional behavior assessment at school, and he needed a behavior plan to help with the IEP. So I'm very thankful for that. And Far Northern Regional Center that offered the respite so that my husband could get that much needed break, because being a caretaker is hard work. And so I'm very thankful for that as well. Next slide, please. I love sayings. I journal. I'm a journal person, and I love inspirational, positive sayings, and these really help me. Parenthood is about raising and celebrating the child you have, not the child you thought you'd have. It's about understanding your child is exactly the person they're supposed to be. And if you're lucky, they may be the teacher who turns you into the person you're supposed to be. Like I said early on, I've learned more from my son than any travel or college class that I've taken. He's taught me more about humanity and the depths of humanity. And I'm just so grateful for that. Special needs parents are the equivalent of Batman, Captain America, Incredible Hulk, combined with a side of Mary Poppins. I gotta have humor. And so that put a smile on my face. And we're superheroes. Next slide, please. Every child is a different kind of flower that all together makes the world a beautiful garden. And all of our children are beautiful. And it's important to find what that is, because there can be a beautiful place for our children in our world. And early on, I saw some of that, and doing the person-centered plan was helpful for me to kind of see that too. A person-centered plan can also be used at an IEP table, taking to your IEP team and helping develop that in the positive areas of your child and their strengths. So it can be used in multiple ways. And it's just important to focus on that. My son still builds Legos here in our community. And there was a Lego store that opened up here in our community, and our son has built and sold his Lego creations, which is his artwork, to this store that opened up. And now his Legos are being sold at the store. So he gets to see the beginning and the end of that process for him. Also, he's a person that he likes to know how things work. And I saw this early on with a sink. I'm just happy to go turn on the water on the faucet and have the water come out, but he needed to know where the water came from. He's looking underneath the sink and trying to figure out, well, what's the piping for? Where's the water coming from? And so my husband has that same interest, so he could do better at explaining all of that. But then we went on the Shasta Dam tour and took a tour of our local dam, which he had very much interest in. So all of these things are so important. Parents of children with special needs create their own world of happiness and believe in things that others cannot yet see. So true. I see the beauty of all of the children, and I just love working here and working with families to find the beauty in their children as well, and to share that. The special needs journey is not about one I planned, but I sure love my tour guide. And it's just been an amazing journey. Next slide, please. I believe it's important for living today, enjoying the moment you have today, celebrating today, and that can be as small as a walk as a mother, time with your child, but remembering that it's today and it's a gift. And worrying is carrying tomorrow's load with today's strength. Carrying 2 days at once, it's moving into tomorrow ahead of time. Worrying does not empty tomorrow of its sorrow. It empties today of its strength. And that's Corrie ten Boom. And so just maybe it's a bath, it's just whatever you need to do to take care of yourself and looking at the moment. Next slide, please. Here again are my parents. in these pictures. They're both teachers and they both brought so much joy and beauty into our family. And it's so important as parents to look at what are your assets when you're raising our children and identifying what those are, because that's going to help you get down that path of working with your child. And my dad there, he's a teacher. They're just, you can see just the joy there. He was the first grandchild, so they really relish those moments. And my mom trying to feed him, they're up in the corner and then holding him. He's a little bit older. My mom is a kindergarten, she's retired. She's a kindergarten teacher. They would read to him constantly. They would give him books. So my son by the age of 4 was reading. That was one of his gifts. Spelling and reading, he did very well. And they just read to him all the time. And one of the beautiful moments that I have is my dad now has passed away. But what he did is he recorded his voice in reading a book, and we still have that recording today. So my son can still hear him reading that book. Next slide, please. Here's some more gifts and talents, inclusion opportunities. The far left, he's in high school there, and they were doing a pumpkin run, and the socialization and the friends that he had because of the great opportunities with his IEP, and we developed a social goal in his IEP. He and I messing around, which is rare. He doesn't like to be touched. So that picture there is a rare opportunity, but he's doing something to make me laugh and he's telling me something. He's got an amazing sense of humor too, and he sees things that I don't always see. So I just love his take on things. The rocket that you can see all those Legos in his room, that race car. He did the Disneyland castle. You can see all the Legos on the floor there, but he built all of that. He's built so many Legos. We have them all over our house and display, and he just loves it, and it helped with his fine motor. And it's a great activity because they have the step book. They break it down in steps, so it's very nice. There's him crawling into a cabinet when he was very young. He liked to bring the world in. The world sometimes would be quite big, and I used to just sit and watch him, much like I did when he was sitting and eating at that meal, because what he did would tell me a lot about what he needed as a child. And so because he couldn't speak right away, but his actions showed me quite a bit. In the rocking chair, he rocked a lot. That told me something. He needed that movement. And so we developed that and put that into his IEP. And then in the bottom right-hand corner, he loves animals. He's playing with those dogs and he's just getting a kick out of it. He's laughing. He just loves animals. So that's another gift and blessing that he has. Next slide, please. Next slide, please. Thank you. Here he is. This is graduation. This is a second glory moment that I had sitting in the bleachers watching him receive his diploma at age 19 on an IEP. And I had tears running down my cheeks. This was a big endeavor. We celebrated big time. And he knew it. And in his IEP, we had accommodations for him to sit down there with his peers and receive his diploma and to wait in line, all of the things. We rehearsed it, and he had a staff person right there down on the field ready if he needed to take a break, but he was ready and he did it. And they had partners that year, so he walked with a partner, and he just did great. The other picture is he laughing at an inclusion opportunity into the community. And I just love to see him laughing. And again, I want to say as a mother, I'm so thankful because he is graduated. He is where he is because of all the services and the love of his family, of being where he is, and all of his hard work in being a partner with that process. Next slide, please.
I think it's possible that we lost the slides. Oh, okay, good. All right. Phew.
That's all right. I'm ready for my next slide. Thank you. So California Children's Services and turning 21, it's just important to talk with the family member about the equipment that might be needed during that transition. And so we talked about, hearing aids. We looked at his shoes to make sure that everything was ready for that transition. We had the final meeting with the CCS doctor to discuss the transition and his individual needs. And then the follow-up of what to do now that we're going through partnership and what does that process look like? It's so getting ready for that transition of what occupational therapy and physical therapy. We're just now, he's going to be, like I said, turning 24. So now we just had a doctor appointment and we got a referral for physical therapy because we're seeing his posture. He's kind of hunched over and walking. And so we need to reintegrate some physical therapy back into his life about appropriate posture and walking and possible other areas that they may see that he may need. So we are bringing that back into our life now and helping him with those needs. Next slide, please. Here's again some of his Legos. He did that free Lego. Again, he likes the holidays. So those are the little Christmas lights and the snow on everything. The left picture is Airports for Autism, which is a fundraiser, and he's out there walking on a tarmac, and that's a friend and one of his caregivers that are out there with him, getting him out into the community and the fresh air. Then the next slide, please. I did not give you the gift of life. Life gave me the gift of you. He is a gift. I think having a child with disabilities teaches you a level of love, patience, protection, compassion, understanding you didn't even know you had. Oh, believe me, I'm such a different person. 24 years ago, I am such a different person than I am today. I'm going to say I'm a better person because of my son. So I just thank you all. Thank you for being here. I think I have one more slide, but thank you for sharing this time with me today. It's an honor to be here. It was an honor to be asked to share my journey today. Thank you, everyone.
Thank you, Monica. That's such a beautiful story, and it's just such an important thing to remember. I mean, everything that you shared is just important for all of us with kids with special needs to remember that they're such a gift to us, right? So, making me weepy. Okay. It's not supposed to happen to your moderator, but it did. So next on our agenda, also a parent advocate is Nancy Netherland. Nancy, I'm going to turn it over to you.
Monica, I don't want to speak after you. What you said is so beautiful and so important and so resonant. And I also, so thank you so much. And also thank you to the other members of the panel and Family Voices for this opportunity. My name is Nancy Netherland, and I'm the parent of two kids. Both have really complex and special health needs. And I'm going to ask you to advance the slide. Thanks. So I'm going to talk about Amelia. I have two children. The first thing I want to say is, first and foremost, Amelia is a young person and a child. And so no matter where we are or what we do, she's always a kid. So these are just some examples of centering childhood on our journey. These are all at UCSF. And one of the things that was really important to me when I realized that this was going to be our path was that I never forget that Amelia was a kid first. So she literally, I don't know if you can see, but in the slide all the way on my right, she's wearing rollerblades and a tiara, and she used to literally roll. The hospital is great, you guys, for rollerblading, the smoothest floors you will ever find. So for years, she rollerbladed and roller skated down those long halls into MRIs and into different appointments. Amelia's enrolled in CCS, and like many kids, I think, our families who are in this summit, she's also a part of a lot of different silos of care. But one of the things I want to take a little step back is to remind us that behind every child who's growing and thriving, and behind every community that is strong and flourishing, are parents and caregivers whose love and devotion and unceasing work make this all possible. So I just want to take a moment to really honor the efforts and the love and the investments that everyone here makes on behalf of children. Sometimes when you have kids like mine who live with complex health needs, you need some extra support to make sure that they can flourish, thrive, and experience childhood, that they have what they need to roller skate down those hospital hallways or do cartwheels when their wrists are feeling good enough. And in my case, that was CCS. This is a story that I like to think of as being comprised of medicine and magic, of biopsies and birthday cakes, and of joy, and sometimes heartbreak. I'm going to ask for the next slide. So Amelia was born prematurely. She's born at roughly 32 weeks with no prenatal care. She started out in the NICU with low APGARs. She had really poor tone. She was jaundiced. She had pulmonary and cardiac issues. I met her when she was a few weeks old. She was also in foster care, withdrawing from an opiate dependency. And she was so tiny. She was in a lot of pain. She couldn't suckle. In addition to cardiac and pulmonary issues, they thought she was probably blind. She was going to have severe cognitive and developmental disabilities. She was, at that point, being cared for by CCS and also just a group of amazing people. But it was one of the first times I met a CCS worker, public health nurse. I'm going to ask for the next slide. I became a caregiver. And with that was a new identity. One of the things that I want to say is we hear a lot about caregiver burden, and it's real. I mean, during this process, ended up losing my husband, becoming a widow and a single mom of 2 special needs kids. And I'm not going to say it hasn't been hard. It's been really hard. But the burden part for me comes when they're not the right resources, or there's a scarcity and what's needed to care for my kids. Actually, there's a lot of beauty in caregiving my kids. There's a lot of opportunity. There are a lot of moments of grace, of joy, and of magic. I feel like I have special relationships with my kids, and especially Amelia, because of the care that she's needed. One of the things that's made my journey easier as a caregiver is CCS and having the resources I need. I'm going to ask for the next slide. Thanks. So this is Amelia now. This is last year, you guys. It's been a really bad 2024. She's had a lot of really serious health stuff. So her care map is not updated, but it is bigger. So Amelia identifies as Black, a teenager, a digital artist, a lover of dogs, a horseback rider, and she also loves ramen and anime. The system identifies her as a medically complex former foster youth, insured by CCS and Medi-Cal, and a bunch of other things, including complex medical needs, specialty behavioral health needs, neurodivergencies, learning disabilities, and an elevated ACEs score. One of the things that I appreciate about our CCS encounters is I feel like they really center in on Amelia's identity, not what she's identified as by the system. She's more than a diagnosis. I'm going to just walk you through this. This is Amelia's care map. So Amelia has a few different diagnoses, and one of them is, it's a systemic autoinflammatory disease, NOS, which means no one knows. That's not the Latin term for it, but that's what it means. And her disease affects every part of her body. So anywhere that blood flows, she can have inflammation. So in the past year, she's lost her sight. It's returned. She's lost hearing. Her brain has swollen. She's had just every system has been impacted. So she's got over 25 medical specialists, which is a lot, everything from immunologists to genetics to hematology. All the things, gastroenterology, and sometimes subspecialist of subspecialists, like we'll see like the one person in the state who will like work with a certain type of oral lesion, or the one person who works with the one type of blood disorder that she has. And it's incredible to me that A, that those people exist, and B, that we're able to have them on our team. I also just want to note that Amelia has a lot of different places that she gets supported services, and a lot of those are through CCS. So Amelia regularly has occupational therapy, physical therapy, nutritional services, and a ton of imaging. And and labs and all that kind of stuff. So the rest of these, so I have CCS in its own little ball here because CCS has really been so important. And I know I can call our caseworker. CCS is not necessarily a high touch program in terms of case management, but it is an imperative program in terms of knowing what's happening with my child's benefits and what's going to be covered and how it's going to be covered. And I don't worry, I don't worry at this point because I know our care manager is going to help make sure that Amelia gets the services that she needs. And the reason it's so important is there are a lot of players here. So in addition to all the medical stuff, she still has some benefits as a former foster youth. She has an IEP. She's been in home hospital. There's a bunch of community services, and there's also a bunch of mental health services, everything from school-based to private therapists to specialty mental health care. So that's kind of our big picture. I'm going to have the next slide come up. This is really small, and I apologize, but this is over 30 medical encounters in less than 3 months. This is the end of January through the middle of April, I think. Anyway, each of those represents either an appointment, in-person, telehealth, phone call, or a chart message. Her care is incredibly complex, and there are a lot of players here. And I also recognize that I feel like we're among the lucky ones that she has, CCS to cover this. Amelia's in the medical center. This also doesn't represent she's been in the hospital a number of times this last few months. She gets infusions every few weeks. And one of the things I want to share is, while I'm not saying that it's a perfect system, I'm saying that it's a system that's worked well in many, many occasions for our family. We were in the hospital recently. Amelia had a horrible reaction to an infusion that has kept the swelling down in her brain and her gut. It's been really imperative to her being able to be reasonably well. And she couldn't use it anymore. And the rheumatology team came in, it was like day 4 or 5, and they were like, okay, we've got a plan, but this medication never gets approved by insurance, and we'd really like to use it. Otherwise, we're going to have to put her back on prednisone. It's got a lot of complications with that. And I said, you know what? I'm actually really optimistic. They said it usually takes so many months to get approved if we get it approved. And I said, we have CCS, and I have a lot of optimism that we're going to get this approved. And in fact, it was approved in a timely manner. And I know that's not everyone's story, but I just feel like it's important to remind myself of the moments where things work beautifully. And in that case, it worked beautifully, and she was able to be discharged sooner. I'm going to ask you to go to the next slide. And this is Amelia. She recently commented to me that the picture on the left, she's in the hospital. And she said, I've spent more time here than anywhere else besides our house, which is really heartbreaking on one hand. And on the other hand, she's getting incredible care. The other picture is her floating around Lake Tahoe last summer. And so it's a both-ended existence, right? We've spent a lot of time in the hospital, and we spent a lot of time enjoying her teenage years and her childhood. One of the things I wanted to touch on, because I think it affects a lot of us, is we often experience extremely long waits to see medical specialists. And I know this is not a CCS direct issue, but it kind of is in a way. I sometimes am aware that is because we need more pediatric medical specialists. And I'm often aware that the waits that we encounter are because there are so many kids who need some of the specialists that are being seen, and that that is not necessarily unique to CCS. I know there's some issues specific to network adequacy that have been addressed in some of the policy discussions. But I also I'm going to say, as a parent, it's been really important to me to support policy and legislative work that supports us having more pediatric specialists in California and nationally. So I'm going to just put that out there and encourage people to remember that those are opportunities for us as families, is to speak up for what we need to people who can listen. As the senator mentioned earlier, it's important. Our voices matter. And that's kind of our story. I do want to say that Amelia, his health has been very unstable. She's going to be entering non-end of life palliative care to help manage her pain and to make sure that she has a lot more access to some of the joys and fun parts of being a young person. And I'm optimistic about that too, because I know that CCS covers palliative care. And I feel like I've had, Amelia's had CCS since she was tiny. And in some ways I've had, along the side of me, I've had this program and these supports that have been really pivotal at each point in her journey. And I can't say how it's been really important. And I feel really fortunate. We're in a traditional county though, where we split our time between Alameda County, and then we spend some time up in the mountains. We have to be near a medical center for Amelia. And so we really, so I just wanted to mention that because we're not in a whole child county. We're not in a county that's converting. We're staying in kind of a traditional model. And one of the things I really appreciate is that the people that we work with are absolutely experts in childhood medical specialties. And I can hop on the phone and I can start talking about like a fine point around like the intersectionality of hematology and immunology. And the person I'm talking with at CCS is completely up to speed on those nuances. And that's been a really important part of our journey. And I really, I know that the work that's being done on Whole Child and some of the other models is really working to make sure that those best practices are lifted into all of those programs. So thank you.
Thank you.
And I appreciate the opportunity.
Thank you, Nancy. That was great. I want to ask if you could turn your camera back on and if we could get the cameras back on for all of our panelists, because we have a few minutes to answer some questions. I've been tracking the questions in the chat. I thought maybe we could start with, there's several questions related to behavioral health for CCS. And I did type in the chat kind of like my understanding of the CCS behavioral health benefit specifically is very narrow because it only relates to behavioral health that's related to specifically to CCS condition. But for a child that's also eligible for Medi-Cal, I think what I'm seeing kind of in the Q&A is a little bit of like frustration about the lack of coordination between those, or how do people access services. And I don't know, Courtney or Monica, or maybe Nancy, because you mentioned that your daughter has, receiving behavioral health services. If maybe the two of you want to respond to some of those questions that came in through the chat about how that's working or not working and how we could make it work better.
Yeah, I'll jump in. So my daughter, getting behavioral health for my daughter. So here's what I know. Kids who live with chronic health conditions have a greater prevalency of downstream behavioral health and or substance misuse disorders. It's well documented. It's been well documented for years. And it has been extraordinarily challenging to get behavioral health resources. I tried to do stuff proactively. Now it's changed. You don't have to have a diagnosis to get care. But I will say that this is something that I look forward to working on in the future, is to make better connectivity. So my daughter gets care through completely separate programs that are not connected to CCS for behavioral health. And it's not even connected to medical specialty. We've been on waiting lists. I think we're on a waiting list for maybe 3.5 years for psychiatry. At one point we were told not to bother. So it's been quite challenging, and I wish I could say that it was an easier system. We ended up, I'm going to be quite candid. I ended up paying out of pocket, getting, friends did a GoFundMe because we could not get the coverage that we needed for her to get them. Because of her medical conditions, we really needed psychiatric consult that could work with all of her different medications. And the delays were so great, and her condition so grave, that we finally did that workaround. We are now, I want to say, getting stuff covered, but we had to go through county behavioral health separately, and we had to wait till she had an acute need in order to trigger the being prioritized to get that health care. So I'm sorry, I wish I could say more about that, but it's been a really brutal system for us.
I have commercial insurance, and I would say it's been hard for me to get mental health for my kid approved, but I think it's probably 100 times worse for on Medi-Cal. I don't know, Courtney or Lael, if you have any suggestions for parents in that regard.
Yeah, I think I have a couple. I think one of the things that is new to the CCS population is enhanced care management and being able to access that, because the CCS population is a population of focus. That's new as of July of 2023. So they can assist with some of those referrals to the county behavioral health system, because I think that is something that is a step and something that they could assist with. Also, I think, over the years, we've broadened our benefit package in Medi-Cal for behavioral health, right? Before early periodic screening, diagnosis, and testing, which maybe people have heard, EPSDT, there was less access, but I think there is more access. But to previous mentions, it's also a provider issue, so not always just a Medi-Cal issue, but just having the amount of providers that are available to do this service. So I think those are some opportunities, and also reaching out to the Medi-Cal managed care plan, which I know probably Nancy did, but really using those buttons. And then also I think we do have services through the regional centers. If you're tied in with the regional centers, there are additional services in top of that. So I think that's an option. Recognizing that I think we're all pulling from the same pool. And so I think that's the piece that I think is some of the struggle.
Yeah. I think there's a comment in here about regional centers too. And I think that question comment kind of reporting to, like, we're all fishing in the same pond for a limited group of providers. I don't know if we have thoughts about how that could be expanded. I think that's a longer term project that I know the state is kind of working on.
And I also just say, Courtney, too, I think a really important change that's happened in the last few years is the investment in school-based mental health. So I just want to say that, like, over this journey, because it's been years for my family, I just want to really acknowledge and appreciate the investment that's gone into making sure that the schools have access for behavioral health resources. And now that kids don't have to have diagnoses, I think it's a lot easier to access that. So I'm sorry, I kind of came up. I've just been doing a ton of advocacy in this area, but I do want to acknowledge that as a really important change. There's also, the new dyadic benefit. It's coming out for like 0 to 5. And so there's going to be more resources earlier in childhood through primary care. So I do want to acknowledge that this is a time of tremendous change, and that what you're hearing is kind of the legacy of an older system, but there have been some really important shifts that I think are going to make things easier. And I just wanted to kind of make a note of that. The school-based resources, especially since so many of our kids do have IEPs, there are now more resources for behavioral health in schools. And it's, I think, a really important resource, or has been, for our family.
That's a good point. There's a question here in the chat about, I think that's related to the first question here in the Q&A. Should there be a better way of getting an appointment quicker than waiting over 3 months for an authorization? I think a referral to a specialist. I don't know if this refers to waiting 3 months for CCS to authorize referral to a specialist, if that's what the questioner is asking.
I was looking at this one in the chat while the rest of the presenters went on, and I think this maybe was tied to the performance measure. So I think what we're trying to do is really thinking about what are the referrals to special care centers, and having these firm deadlines, right? And making sure that we're all working towards that. And then that'll give us an opportunity to see where are the outliers and where do we need to provide technical assistance. So I think that's what the question was tied to, but not exactly sure. But I think, of course, the referral should be happening much sooner. But in order to improve compliance and be able to assess and provide technical assistance and holding people to standards, we have to start, somewhere and then work our way. But ultimately, we're really, with this measure, looking for the outliers so that we can work towards bringing them all closer together, so that the care delivered statewide is consistent.
Right. I think we sort of addressed the question that Lisa Scheuer, I think is the way to pronounce her last name, was asking about, the regional center clients and authorization for services waits are long. I think that Kaiser does have, I don't know about a lawsuit, but they were fined by the Department of Managed Healthcare for issues related to access and behavioral health. I think that question was answered. And then there's a couple questions here from somebody related to children who have Medi-Cal as a secondary insurance and a requirement that they have to join a managed care plan. Courtney, I don't know if you have an answer to that one.
Yeah, so as maybe over the past few years, the Medi-Cal beneficiaries are moving into managed care. There are a few groups that are voluntary in managed care, things like our foster care kids, as well as our people in our tribal beneficiaries and some others. But I think most people are moving into managed care. So I think that's what you're speaking to. There are opportunities to file a medical exemption request if it's kind of tied to care needs, and you can kind of maybe I can find something in the chat to pop in how to file a medical exemption request. But yes, most people are required to sign up with a Medi-Cal managed care plan, even though their CCS benefit is fee for service, right? If you're in a Classic county, so you could have LA Care health plan, but have LA County Classic CCS. So your CCS benefit might still be fee for service, but the rest of your preventative and primary would be tied to a managed care plan. But that has happened over the past few years with the last set of people moving in on Jan 1, 2024.
And also, but those people can also request continuity of care, right, to remain with their provider?
Within the first 12 months.
For the first 12 months anyway. Okay. There's a question in the chat, in the Q&A about with disasters increasing due to climate change, what measures is CCS taking to assist families in these circumstances to assure continuity of care? Lael or Courtney?
I'll speak to kind of some of the things we're starting. This is a new territory for us as well, right? But one of the things is we have required reporting by the counties if there are areas in which the state can assist. I think, sometimes it's, unfortunately like urgent, but if there are systemic things that we can help with to start shoring up the protocols when a disaster happens, we've been starting to do that. So we reach out to the counties that are impacted. We are notified by the Office of Emergency Services in the governor's office of areas where they are looking for us to reach out and to see if we can provide any support or assistance. I think sometimes other entities are before us, right? But I think we do reach out and inquire and try to assist and see what options we have to provide.
Thanks.
I would add to that, most of us in CCS are in the Department of Public Health, and the Department of Public Health really takes the lead for public health disasters. And so we work with Department of Public Health and the managed care plans being a whole child model in trying to figure out how do we support the residents of the county.
Thank you. Next question is, will CCS be looking at services from an equity lens of the barriers of working families? Services are currently held in office and during certain hours that provide some stress and are barriers for families, especially people of color and working families.
I can't speak to the provider community, but I can say that, as a result of the public health emergency, our telehealth policy is much broader than it used to be. We allow for most things at the provider's discretion to be provided via telehealth. Of course, when you're doing maybe your first or your annual special care center visit, probably would be better to go in just to have that face-to-face contact. But we know that there's things that come up where you can really do it via telehealth. So I think that's one opportunity. I can't speak to provider office hours, of course, but I think we are trying to see what other modalities are available, which really didn't exist too much. Our telehealth policy before the pandemic was quite limited. It was mostly for the behavioral health space and wasn't really for the physical health space. And so I think that is one thing that you can always request. And Medi-Cal is really defers a lot to the provider on how to operationalize that. And so that gives them an opportunity to bill, and that thus gives the members a different point of access.
Thanks for that. I am also going to drop in the chat that the department recently released a health equity roadmap. And I don't know it just might be a useful thing for people to take a look at and see if they have comments on relative to the department's efforts in that regard. Will enhanced care management provide the missing proactive medical case management by health plans? Are health plans providing in-person case management or solely via phone?
So I think one of the things that I had mentioned kind of in my update was the point of contact, a specific person at the plan who would be the case manager. And so that will be something that we'll be rolling out as a policy, and then will be effective January 1, 2025. So I think, finding that out, I think ECM is a great opportunity, especially if the kid the CCS kid has other complexities, right? Because that person can help be that kind of pivotal case manager and connect with, as I mentioned, maybe the county behavioral health system, maybe if they're on a waiver program, like maybe on our home and community-based alternatives waiver or other programs that help support kids with needs. And then also so they can coordinate with home health agencies and things like that. So I think it really is, we don't see that person as in place of the whole child model case manager, but maybe if there are other needs outside of the CCS eligible condition, that would be an opportunity for that person to assist. They also work on things like social determinants of health, which is slightly outside of the CCA's case manager's kind of scope of work. And then I think the other piece that we're doing is really defining what case management means for CCS, right? So there'll be policy guidance that will be issued this year, just to ensure, because I think Lael mentioned in her presentation, that concept of like, I'm a case manager as well by training, and how I define case management and how other people define case management are slightly different, versus also kids in CCS have different case management needs than adults. And so I think those are the things that we're going to be providing future guidance on, because we want the case management definition to be applied to the whole child model plans, but also our counties, right? And so we have a definition in what we consider core activities, because the definition alone could still be, not interpreted in the same way, but those core activities of, providing referrals, providing more handoffs, different aspects, making sure that there's special care center visits and things like that. So I think those are the things that will help, because I think everyone wants to do the right thing, but case management means different things to different people. I think that's where ECM has a little bit more structure around it of what they can do to support, right? There's a policy guide that helps the case managers in that program know what the requirements are. And I think that's something similar we need in this space. That seems to be an area where we've heard from members and stakeholders and so I think that will be helpful, and that will go out for, public comment. We'll make sure that Family Voices is on that public comment list to give feedback on that, because I think that is really key. We've been asking for feedback in the different work groups, but when you see it in writing, it always hits a little different.
Thank you, Courtney. I'm being given the hook, which I just can tell because Nick has just joined on camera. So that's all the questions we have time for. I did see some questions here related to Medi-Cal RX and high-risk infant follow-up. I think, Nick, if Family Voices can capture all those questions, I'm sure we can work with the department and others to see if we can get answers to some of those questions. Moving forward, there's a question about Cal Optima in the chat. So if we can gather them all in one place, we can maybe try to farm them out and get everybody answers. But in the meantime, I just want to thank everybody, thank all the panelists for joining this morning, and for a great conversation, and for really a lot of inspiration coming from the parent advocates in particular. So thank you very much.
Absolutely. And again, I will absolutely capture all of the information and be sending it off to the appropriate people so that we can work on some answers for you. So please don't think that because we're running out of time that your questions are not valuable. I'd like to thank Anne, Courtney, Leo, Monica, and Nancy. Unbelievable. CCS, very complex. And again, your time is very valuable, and I know it was very informative. And again, we'll get those questions answered. It's been a long morning already, and we have more to come. So right now is the time to take a break. We're coming back at 11:45. We're going to be hearing special messages from Assemblymember Patterson as well as Bennett that are recorded for us because they could not be here in person. So we hope that you'll join us for that as well. And then right after that, we have our breakout sessions. So we have a breakout session on Medi-Cal, peer support, the whole child model, and cultural competency. You'll be able to join from the main area that we're in. So again, we just appreciate the time that you've spent with us. It's time to stretch your legs, come back and watch those videos, and then go ahead and join the session that you feel would be most helpful for you. And again, thank you to the panelists for unbelievable plenary.